All right, welcome everybody. Chapter 30, multi-system trauma. This one's a pretty quick one. It's an overview of things, and it's just things to keep in mind when you have somebody that has what's called a multi-system trauma. So we'll get through this relatively quickly. All right, so what is a multi-system trauma or a multi-system patient? A multi-system patient is a patient that has more than one serious injury. It's as simple as that. A multi-trauma patient, multi-system multi-trauma patient is a patient that has injuries that affect more than one system. Okay, so it's cardiovascular and respiratory systems, GI, other things like that. These are patients that require teamwork, good critical thinking, and rapid and correct decision making to manage them properly. So we've got several critical decisions that need to be made when we're dealing with a multi-trauma or multi-system trauma patient. Okay, so for our most critical decisions, we have to quickly decide what the patient's priority or the severity of the injuries are. Luckily for us, not so much the patient, but luckily for us, a lot of times this is going to be readily apparent very quickly when we first come in contact with our patient, we first are able to see them. So decisions like high priority, it's basically it can be like a yes or no question at this point. You see as somebody that's been hit by a car, are they high priority? Yeah, probably, right? Right away, we're going to know that. We're also going to know right away whether or not that we can stay and play on scene, or if we got to load and go. So again, remember with those trauma patients, right? We've got the platinum 10 minutes and the golden hour. We want to spend very little time on scene because the best treatments for them are going to be in hospital, probably on an operating table. So we can decide quickly priority and whether or not to scene time, how much time we want to spend on scene there. But other decisions that may take a minute are going to be which hospital. Is this okay just to take somebody that's been hit by a car just down to Augusta Health or Centera, something like that, or do we have to go over the mountain? And if we do have to go over the mountain, are we going to drive them? Or are we going to fly them over there? So we have to figure out which transport method is the best. So if we have multi-system trauma patients, we want them going to the trauma center, obviously. And most likely the best way to get them there is through air care or air transport. Have them flown in the helicopter. All right, so how do we determine how severe they are? Now, again, we can make quick decisions based on just how they look, right? Our initial impression there when we get in there, our general impression of the patient. But there are some criteria that we're going to look at. So if we remember back to last chapter, the GCS or Glasgow Coma Scale, right? Remember that all of us are 15s, right? We're 15s walking around. We're alert and oriented to everything. We've got good eye movement, we've got good motor response, things like that. So any altered mental status, which is going to be anything below 14, right? So we're 15s, but anything below a 14, they're going to have an altered mental status. So if they have a head injury, for example, that's probably going to produce that 14. So if they're anything less than 14, that is determines a severe patient. Another sign for determining severity is going to be their blood pressure. Okay, so anything that's below 90 is unstable. It's very unstable. So obviously it's a sign of shock. It could be internal or external bleeding there. And the term that we use for this is when somebody is hypotensive below 90 there is that they are hemodynamically unstable. Hemodynamically unstable. That means their blood pressure is below a 90. Obviously, we know that's bad. That's not good. So keep an eye out for that. Another sign of patient severity there. A third sign here will be abnormally slow respiratory rate. head injuries, right? So we have the Cheyne-Stokes breathing pattern, which is obviously, if we remember what that is, a sign of a severe head injury there. We can also have those ataxic respirations, which are completely irregular, which are obviously really bad. And then we can get in the very late stages of shock when they're decompensating and they're circling the drain, so to speak. That patient is going to be starting to breathe very slowly, right? When their body systems are failing to compensate, when initially their respiratory rate goes up and their heart rate goes down, that stuff eventually starts getting slower and slower. All right, so those were physiologic criteria. So here's some anatomic criteria for severity of multisystem or multi-trauma patients. We'll have any penetrating injuries to the head, neck, torso, or extremities proximal to the elbow and the knee. All right, so that means anything that's above the knee or above the elbow. So this is because obviously there's some large blood vessels that are involved here, so they're pretty good in diameter, so they can be susceptible to injury with penetrating traumas there. Chest wall instability or deformity, right? So this is going to give us large breathing problems if we have that chest wall instability or deformities. So what's that called? What's that injury called? When we have a segment of the chest wall, right? Two or more ribs broken in two or more places there. Paradoxical motion. You guys remember what that's called? What could that be called? Anyways, if you have that, if you remember what that injury is called, you have that. That is obviously a sign for anatomic criteria there for severity. Remember what it is? Flail chest. Flail chest is the answer there. Also, if you have two or more proximal long bone fractures, okay, so that means the humerus or femur long bones, okay. So if you have two or more humerus fractures or two or more femur fractures, right? So maybe that's two femurs and a humerus, or two femurs, or a femur and a humerus. Whatever the combination there is of two or more proximal long bone fractures. Another anatomic criteria for a patient with a severe trauma. So mechanism of injury, again, just like the last chapter and all these trauma chapters, we've had to deeply consider the mechanism of injury for the patient. It's always something we got to think about, right? So if we're not seeing any signs, if the patient's up and around at the scene of an accident where their car rolled over or they were tossed from the car, ejected from the car, then we have to, and they're not showing any signs of injury, then we need to consider the mechanism of injury here for severity. So if they've fallen from a great height, so for an adult it's 6 or more, greater than 2 times their height there, and for kids it's 6 feet or 3 times their height, or 10 feet, or excuse me, 10 feet or 3 times their height. Intrusion, that means intrusion into a vehicle. So if let's say car A is T-boned by car B, if car A, if the doors are pushed in any amount, that's called intrusion. Now what we want is 12 inches directly next to that passenger. Okay, so 12 inches next to that passenger, or 18 inches anywhere in the car. So if somebody, let's say in car A, which gets T-boned by car B, if the driver in car A, if his door is pushed in 12 inches, then that's a severe mechanism of injury. If driver of car A, if let's say the right side rear passenger door If there is where that his car gets T-boned, if it's pushed in 18 inches, then that's severe mechanism of injury. Okay. Obviously, ejection from an automobile, very dangerous. Always wear your seatbelt. But the likelihood of severe injury is high when that happens. Death in the same passenger compartment. Now that's because enough forces were applied to somebody else's body to kill them, and they could have been applied to your patient as well. So that is obviously important to take into account there when thinking about severe mechanism of injury. They could absolutely have had those forces applied to their body as well. And then there's vehicle telemetry data. So I've not seen this in the field, but if a lot of times, there's police departments that have this. I'm not aware of EMS departments, but they can plug into the car's computer, and if it says it was going 70 miles an hour before it hit a brick wall, then that data that's telling you that, you can say, okay, that was a severe crash. But I'm guessing you would be able to see that upon arrival, that there was a high speed involved and things like that. Usually, if you'll be able to take in context clues in the environment about how severe things like car crashes were. All right, so in determining severity, there's a couple considerations here for special populations and patients. Um, Older adults, the elderly, they don't compensate well for shock. They just don't do it very well. Their bodies just can't handle it. As we get older, our ability to handle trauma is lessened as we age. So they don't efficiently compensate for shock, and so their mechanisms may not be working as well as a young person's mechanisms to compensate there. Um, there are pediatric centers. They are specialty centers for kids and kids alone. They specialize in pediatric patients, and so if you're in an area that has a pediatric specialty facility, you may want to consider transporting there rather than to just your regular trauma center. It all depends on the availability and what your region's protocols are. Now, there's certain conditions that we have to take into account for trauma. The first one here is patient taking anticoagulants. Hopefully you remember that anticoagulants are basically blood thinners. So if your patient is taking a blood thinner, what do you think? Are they more at risk for having hemorrhages that aren't easily controlled? Absolutely. How about that elderly person that falls and hits their head and they get a hematoma, subdural hematoma, epidural hematoma, something like that, maybe an intracerebral bleed? You think that's going to be worse than somebody who's not taking an anticoagulant or blood thinner? Absolutely, it's going to be worse. So we have to know if they're taking, if somebody's taking blood thinners. Okay, it's a great question to ask in your sample. Are you taking blood thinners? Also, obviously, another condition that we should know about is if a patient is pregnant there. If late-term pregnancy, we'll be able to probably see with our own eyes without having to ask that they're pregnant, but it may be harder to tell with some patients. And if they're earlier in the pregnancy, obviously it may be impossible to tell. So that is a good question to ask for women of childbearing age who are in traumatic situations like that. Are you pregnant? Okay, how do we manage these folks? Um, well, you're going to see here that it's pretty common sense. Pretty common sense how we manage these guys. So when you get out there in the world and you start volunteering and you start working, you're going to have to practice with your crew, and you're going to determine roles. Oftentimes on the way to a large accident, or where you may have patients with multi-system traumas, or you know that it's going to be hectic, the officer in charge or the attendant in charge, they may hand out roles on the way. Like, all right, Sally, you're going to be getting the backboard and the cot and the bags. Johnny, you're going to be in charge of doing the 360 walk around view of the car. Ricky, you're doing the trauma assessment, the rapid trauma assessment there. Jane, you're doing vital signs, right? Everybody gets a job before they get on scene, and so time spent can be spent wisely and efficiently, so you don't have to spend a lot of time on scene there. So you may get your roles prior to arriving on scene. It's difficult with scene safety sometimes, but it's paramount that it's always on the front burner. It's always in your mind. Your safety, your health and safety is always, always, always priority number one. So some of you have ridden on calls where you've been on streets, maybe highways, and oftentimes those are the most dangerous places that we can be. People are rubbernecking on the highway. They're not seeing us out there working despite having our vests on or flares out and things like that, right? Maybe there's drunk drivers out there, things like that. So you have to be really aware of your safety on accident scenes, motor vehicle collisions. You have to be aware of that. Penetrating trauma, a lot of times a penetrating trauma is the result of somebody doing that to somebody else. Did they shoot them? Did they stab them? Things like that. So make sure your police force that you're working with there has secured the scene before you go in, right? That assailant may still be in the area, may even be on scene. You never know. So keep that in mind. All right, so obviously with these patients, as with any patient, you're going to do your primary assessment when we're going to make sure we've got a good patent airway or that we're keeping it open. Perform any urgent or emergency moves, get them out of the scene as quickly as possible, and then start transporting. Let's see, now when I say as quickly as possible, obviously do it as safely as possible for yourself and the patient, right? So if you need to do any C-spine or spinal immobilization maneuvers, then do that, obviously protect your patient. Now, when you do have a multi-system patient or a multi-trauma patient, you definitely want to know, let the receiving hospital know what you're coming with there, okay? So this part here, it says, give a report to the trauma team at the emergency department during handover. Yes, you're going to give a good, quick, but thorough report while you're doing the handoff of the patient, while you're actually there. However, before you get there, you got to let them know what they're going to be expecting to come in, what you're bringing in. All right. So, age, sex of the patient, mechanism of injury, and the patient's current injuries, vital signs, and any treatments, any interventions that you've done, and obviously ETA. Like how long do they have to prepare for you to get there? So when you have a patient with these critical injuries, your priorities and your treatments are going to be determined by your assessments, namely our primary assessment. We have to do ABCs and do ABCs really well. Is that airway open? Is it going to stay open? What do we need to do to keep it open if it's not? OPA and NPA, right? Airway maneuvers, head tilt, chin lift, or jaw thrust there. Breathing. Do we need to support their breathing with supplemental oxygen and like a bag valve mask, doing PPV, positive pressure ventilations? And bleeding, circulation. Stop any bleeding. Here's something that's really critical. Don't delay any transport time by performing treatments that would waste time. We're not going to be splinting broken bones, things like that. We're going to put them on a backboard. If we can splint them on the way, then awesome. We'll splint them on the way. But we're not going to be spending time on scene doing treatments like that. Any of those interventions are not necessary in that moment. So critical thinking and good judgment really come into play here. Um, we don't need to get vital signs on scene. Right? We can take those in the back of the ambulance on the way. Um, we can do other treatments if necessary on the way. Right? Don't waste time on scene in doing those. And as we said, give the hospital staff time to prepare. All right, they'll need time to let their team know that they've got a patient coming in, and they need time to digest the information that you're going to give them over the radio. So give them a heads up. Make sure you have a good, complete, concise, and efficient report to give them. Now, if you don't have vital signs yet while you're calling it in, fine. Tell them you're going to call back in a minute when you have them. Right? But get on the horn early and give them the most complete amount of information that you can. So as we said, depending on your primary assessment, you might be busy, and so you may need to postpone taking vital signs until you're en route to the hospital, and that's fine. That's fine to do. If you're busy doing other things, then do those other things. If you're shorthanded, or if you're just so busy with all of the injuries that are there that you have to take care of, or you're suctioning, you're doing head tilt chin lift or jaw thrust maneuvers, you're PPVing, you're giving oxygen, all those things, you're busy on top of other people like controlling bleeding and things like that, you may not have time to take vitals. And that's okay. You just do the best you can. So you can obviously always give updates on your patient's conditions. So if things change, you can call back in and say, hey, things have changed since 5 minutes ago. And this is what the situation is now. All right, so here are some of the treatments that we're going to consider doing on the scene. All right, so some of these treatments to limit our scene time, we're going to obviously do some stabilization of cervical spine, right? That's common sense. If we need to suction the airway, right? That's common sense. If we need to do an OPA or NPA, again, common sense. Opening the airway with maneuvers, common sense. Ventilating with bag valve mask, right? Doing positive pressure ventilations, giving oxygen, controlling bleeding, immobilizing the patient on and backward. All of these things can be done on scene with the multi-system or multi-trauma patient. These are all common sense. We need to be able to do these. Obviously, treatments in our primary assessment, and then stabilizing spinal injuries as well there. So while scene safety is always paramount, I mean we can't speak about this enough. Your priority or your priority is your health and safety, no matter what. It's always your health and safety there. Um, do your ABCs, open the airways, help with breathing, stop any bleeding there. Um, Try to be light on your feet in your thinking. Okay. Um, Things that may seem grotesque with injuries and things, they may be able to be handled later. We don't have to necessarily splint a leg that looks like a figure eight, right? Maybe we can do that, if at all. Maybe we can do that in the back of the ambulance, right, instead of on scene. Right? So be fluid. Be like the river. Be fluid. Be adaptable to the situation there. Your patient will be much better off for it. All right, so we're going to talk about trauma scoring here for a little bit. It's called a revised trauma score. It gives you a rating on how bad your patient is. It assigns your patient to numbers based on certain criteria, and it tries to describe or give a rating to how severe your patient's injuries are, or how critical the patient is. Um, and it helps the hospitals too. So there's three components to it. It's their GCS score. I might need to know how to calculate a Glasgow coma score, right? Make sure you can do that. Their systolic blood pressure and their respiratory rate are also included. So while it's nice to have this, you don't want to stop any kind of care and be like, I need to get my revised trauma score here, all right? If you don't have the time to do it, and you don't have the time to do it, just like vital signs. Like if you don't have the time to do it, you don't have the time to do it. We may be busy doing other things. If you can get a revised trauma score, you want to. So here it is. We got this nice little chart here. So uh, uh, your Glasgow coma score, everything is out of 4 points. First of all, how many points you get scored. Um, so 4 is the most, 0 is the least in this one here. So your Glasgow coma score, if you're 13 to 15, you get 4 points. 9 to 12, 3. 6 to 8, 2. 4 to 5, 1. 3 is 0. Your systolic blood pressure, if you're greater than 89, right? If you're 90 or above, you get a 4. And then they start doling out points for below 90, below that. And then your respiratory rate, if you're between 10 and 29, you get a 4. If you're greater than 29, you get a 3. If you're less than 10, you either get a 2 or a 1. If you get 0, you get a 0 if they're not breathing at all. So it is good to know these. Oftentimes, regions will hand out protocol booklets that you can fit in your pocket, or if you have it as a saved page on your phone, you can whip out your phone and bring that up really quickly there. So otherwise, you need to commit it to memory, and in the heat of a situation, this may be tough. So be aware of what this is and how it is scored, okay? And realize that you may be asked for this. So be aware. When you find your region's protocols, look through the protocols for the revised trauma score sheet, or find this and save it on your phone, okay? Okay, look through the multimedia library on the website in your My Brady Lab, and you can look at those animations there. Almost done here is a quick review. Multi-system traumas, they're serious conditions. 2 or more major body systems are affected. Recognizing it quickly and adapting to this. So that means triaging appropriately, saying how serious this patient is, getting them transported, meaning spending very little time on scene, and choosing the correct destination and method of getting them to that destination. There are critical decisions there. For trauma triage, like what is the appropriate criteria for somebody being this multi-trauma or multi-system patient? Please know those, right? So there were several to think. There was physiologic criteria, there's anatomic criteria, there was mechanism of injury criteria, and there were special considerations, right, for elderly folks, for folks taking different types of medications, and for pregnant folks as well. And the revised trauma score, know that not only that it's there, but how to score it. Okay, be aware of it. Find a picture of it. Search online for a picture of it. Download the picture that was on the screen right there a moment ago, and save it so you can in a place where you can pull it up quickly if you needed to on your phone. All right, so our assessments are going to determine what our treatments are going to be, and obviously our primary assessment, we do that first. That is going to drive our goal of treatments, at least at the very beginning and maybe throughout the call. You may be having to handle airway issues the entire time. Maybe you're handling breathing issues the entire time. Maybe you're working on controlling bleeding for a long time. All right, so your assessments, you're going to have to, when you get past the primary assessment, or even in the primary assessment, you're going to have to determine what needs to be taken care of right now, what needs to be taken care of next, and what is less important and can be taken care of a little further down the line. Just like in a rapid trauma assessment, we're cataloging and prioritizing any injuries and things like that, and so we may say, all right, this is more important than that, and move on down the line. So your assessments will drive what your treatments are. Questions to consider: is my patient seriously injured or potentially seriously injured? Luckily, a lot of these times are done in our scene. These decisions can be, questions can be answered rather, in our scene size up. You walk up to a car that's obviously it's on its roof, all the windows are blown out, and it's obviously flipped over a number of times. Is your patient seriously injured, or could they potentially be? Yes, absolutely. That question is basically answered before you even have to ask it. So is the next question. Should I expedite my scene time? Should I spend very little time on scene? That question is going to be answered basically in the same moment you answer the question if your patient's seriously injured or could potentially be seriously injured. And then what you may have to think about is what's the most appropriate transport destination and how to get there as well. Okay, for this critical thinking exercise. A patient was involved in a car crash with significant intrusion into the area where the patient was sitting. The patient is alert and complains of pain in the ribs. Pulse is 96 and regular. Respirations are 30 and adequate. Blood pressure is 100/62. Pupils equal and reactive. Skin is cool and dry. Your partner says the patient is stable and could be easily transported to the community hospital nearby. You think the patient should be transported to the trauma center. How would you justify your decision to your partner? So what do you think? Is this patient stable? Are they able to go to just a regular old hospital? Is there anything in here that tells you that they should go to a trauma center? Well, our vitals are right on the line, aren't they? So our breathing rate's a little high, it's at 30. Our blood pressure, it's right at 100, right? Our systolic's right at 100. So that would be worrisome. That might be a sign that there's some internal injuries, maybe right around where their ribs hurt. Maybe there was blunt trauma that's causing some caused some internal bleeding there. So if that is the case, then they need an operating table, right? And better to be safe than sorry. So maybe we should take them. We should be proactive and make a decision to take them to a place that could handle injuries like that. And that would be a trauma center rather than your regular hospital. That would be the decision that you would want to make. Okay, if you got any questions, shoot me an email and let me know. And we'll have a meeting in the next couple of days on Zoom where you can ask any other questions that you may like. All right, thanks. See you guys.